let's talk about diabetes. Now, I know what you're thinking. Sugar, right? But what if I told you there's a whole other kind of diabetes, one that has absolutely nothing to do with glucose and everything to do with water? That's right. Today, we're diving deep into the fascinating and frankly often missed world of diabetes insipidus.
So here's our game plan. We'll kick things off with what it actually is, and spoiler, it's not what you think. Then we'll get into the root causes, how it messes with the body's plumbing, and the telltale signs you'll see in a patient. After that, we'll cover the investigations and, of course, how to manage it, with some key takeaways you'll definitely want to remember.
Okay, first things first. Let's clear up this whole diabetes name thing. It's a huge point of confusion, but once you know the origin, it all just clicks into place.
You know, the name itself tells you everything you need to know. The word diabetes just means to pass through, like a siphon, which makes sense, right? Lots of urination. But the second word is the key. Mellitus is Latin for honey sweet. You can guess why. But insipidus, that means tasteless or bland. So right from the get-go, we know this isn't about sugar. It's all about tasteless, dilute urine. It's a water problem.
So what are we actually talking about here? Well, diabetes insipidus, or DI, is pretty rare, about 1 in 25,000 people. At its core, it's a simple breakdown in the body's water-saving system. For some reason, the kidneys lose their ability to concentrate urine. This is all because of a problem with antidiuretic hormone, or ADH, and the result? The patient is just pouring out huge volumes of incredibly dilute urine. It's like their body's faucet is stuck on full blast.
Now, DI isn't just one thing. We've got to look at the 4 main suspects here because where the problem lies changes everything. First, there's central DI. That's where the brain just isn't making enough of the hormone ADH. Then you've got nephrogenic DI, where the brain is sending the signal, but the kidneys are completely ignoring it. Dipsogenic DI is a whole different beast. It's a faulty thirst mechanism making someone drink way too much. And lastly, there's a temporary type, gestational DI, that can pop up during pregnancy.
All right, let's dig into the why. Understanding the root cause, the etiology, is everything. I mean, it completely changes how we're going to treat the patient. Each of these types has a totally different backstory.
So for central DI, you're looking for things that can damage the brain. Think head trauma, pituitary surgery, tumors, or sometimes we just don't know the cause. It's idiopathic. Now for nephrogenic DI, the kidney problem. This can be something you're born with, a genetic thing, or it can be acquired. And the classic culprit here, the one you always have to think about, is lithium. For dipsogenic DI, it's damage right to the thirst center in the hypothalamus. And that temporary gestational DI, it's wild. The placenta actually starts making an enzyme that just shreds ADH before it can even do its job.
Okay, now for the really cool part. How this all works. Or, well, how it fails. The body's water balance is this beautifully precise system. So to really get what's going wrong in DI, we first need to see how it's supposed to work. So here's the normal process. When you get a little dehydrated, your brain senses it and sends out the signal molecule ADH. ADH travels all the way down to your kidneys. Think of it like a key. It finds its lock, the V2 receptor, and turns it. This tells the kidney cells to open up these special water channels called aquaporin 2. These channels then pull water out of the urine and back into your body. Simple, right? You save water and your urine becomes more concentrated.
And this is where it all goes wrong. This shows you the 2 main failure points perfectly. On the left, with central DI, the brain just never sends the signal. There's no ADH. The kidneys are ready and waiting, but the phone never rings. On the right, with nephrogenic DI, the signal is being sent loud and clear. In fact, the body might be screaming it, but the kidney's receiver is broken. The message arrives, but no one can hear it. Center problem versus receiver problem.
So when this elegant system breaks down, what does it actually look like in a patient? Well, the signs are pretty dramatic. A patient with DI is, well, they're hard to miss once you know what to look for.
The classic signs are what we call polyuria and polydipsia, peeing a lot and drinking a lot. And I don't mean a little bit. We're talking huge amounts, sometimes more than 3 liters a day. This, of course, leads to nocturia, getting up all night to go to the bathroom. Patients are exhausted. They often have this intense, specific craving for ice-cold water. And if you see this in kids, the red flags can be different. They might just be failing to thrive, have weird fevers, or be super irritable.
Okay, so you've got a patient who looks like this. How do you prove it's DI? And, just as important, how do you figure out which type it is? This is where we put on our detective hats.
It's a step-by-step process. First, you do the easy stuff. Check blood glucose and electrolytes just to make sure it's not something else. Then comes the gold standard, the water deprivation test. Under close supervision, you stop the patient from drinking and see what their kidneys do.
A normal person's kidneys will go, whoa, no water coming in, better save what we have, and they'll produce concentrated urine. But a patient with DI, their kidneys just keep pumping out dilute urine. It's like they don't even notice. That right there confirms DI. Now for the tiebreaker. Once we know it's DI, we need to know why. So we give them desmopressin, that's just synthetic ADH. And the response tells us everything. If it's central DI, the problem was just the lack of the hormone. You give it to them and suddenly their kidneys work perfectly. The urine gets concentrated. But if it's nephrogenic DI, you give them the hormone and crickets. Nothing happens. The urine stays dilute because the kidneys were the problem all along. They just can't respond to it.
This is so important for putting all the pieces together. Ruling out diabetes mellitus is easy, right? Just check for sugar in the urine. The real head-scratcher is telling DI apart from something called primary polydipsia, where people just drink too much water out of habit or a psychiatric issue. The key difference is in the labs. DI patients are fighting dehydration, so their sodium is often high normal. Polydipsia patients are waterlogged, so their sodium is low normal. And on that water deprivation test, the polydipsia patient's body will eventually kick in and concentrate their urine. The DI patient's body just can't.
All right, we've got our diagnosis. Now, how do we fix it? The key here is that the treatment has to be tailored exactly to the type of DI we're dealing with.
But before we talk about any medications, there is one rule. Rule number one, the golden rule, the one you can never, ever break. A patient with DI must have unrestricted access to water. Their constant drinking is the only thing keeping them from severe dehydration. Taking that away is incredibly dangerous. It is their lifeline, period.
So the strategies are completely different based on the type. For central DI, it's easy. The brain isn't making the hormone, so you just give them the hormone. Desmopressin. Same for gestational DI. Now, nephrogenic DI is where things get interesting. You can't just give the hormone because the kidney won't listen. So you use this brilliant clinical trick, a low-salt diet and a thiazide diuretic. I know, a diuretic for someone peeing too much, it sounds crazy, but it works. By making the early part of the kidney tubule pull back more salt and water, so less water even makes it to the broken part of the system at the end. It's a fantastic workaround. And for dipsogenic DI, no drugs. Giving them desmopressin would be dangerous. It's all about behavioral therapy to help them manage their drinking.
And we really need to get this right, because leaving DI unmanaged is serious business. The immediate risk, of course, is severe dehydration and dangerously high sodium levels, which can cause confusion, even seizures. But think about the long term too. The constant high flow of urine can damage the bladder. And just imagine the psychological toll. Being chained to a water bottle in a bathroom can lead to incredible anxiety and social isolation.
Okay, let's boil this all down. What are the absolute must-know pearls? Number one, DI is about water, not sugar. Think tasteless urine. Number two, the classic lab picture is a patient who is concentrated on the inside, high serum osmolality, but pouring out dilute urine, low urine osmolality. It's a paradox. Number three, your key test is water deprivation, followed by the desmopressin challenge. And number four, central DI gets better with desmopressin, nephrogenic DI does not. That's the fork in the road.
And for treatment, the pearls are just as simple. Central DI, you give the hormone. Easy. Nephrogenic DI, you have to work around the problem with things like thiazides and a low-salt diet. Dipsogenic DI, you do not give the hormone. You can cause a disaster. And finally, the golden rule, say it with me, never restrict their access to water.
Look, if you walk away with only one thing today, let it be this. The key to understanding almost everything about DI comes down to one simple question. Is the problem with the sender or the receiver? Is the brain not sending the signal, or is the kidney not listening? If you can answer that, you can figure out the rest.
And I want to leave you with this quote because it really drives home why this matters. DI can lead to poor quality of life and even increase mortality for patients, making prompt diagnosis and treatment critical. This isn't just some quirky, rare disease. It has real consequences for our patients. Understanding it, diagnosing it, and managing it correctly, that's our job.